Hello, this is Sarah Myers, and this is a geriatric syndrome presentation that focuses on dementia. What is dementia? Dementia is not a specific diagnosis, but rather a general term used to describe cognitive impairment and behavioral disturbances caused by brain damage that interferes with a person's daily life. There are several diseases that fall under the umbrella of dementia. These are Alzheimer's disease, vascular dementia, mixed dementia, Parkinson's disease, Huntington's disease, Lewy bodies, frontotemporal dementia, Creutzfeldt-Jakob disease, normal pressure hydrocephalus, and Wernicke-Korsakoff syndrome. Who does dementia affect? Dementia predominantly affects people 65 and older. As of right now, there are 50 million people worldwide that have dementia, and another 10 million that will be diagnosed annually. In the United States, 14% of older adults aged 71 and above have dementia, and 2/3 of those are women. Alzheimer's disease is the most common type of dementia, and it accounts for 50 to 75% of all dementia cases. The Alzheimer's Association reports that approximately 5.7 million Americans suffer from Alzheimer's disease. Vascular dementia is the second leading cause of dementia, accounting for 20 to 30% of dementia cases. Lewy bodies and frontotemporal dementias account for 10 to 25% of cases. Like many other diseases and diagnoses, several risk factors have been identified for developing dementia. A genetic predisposition has been identified in the development of dementia. Another non-modifiable risk factor is being female. Modifiable or treatable risk factors include hyperlipidemia, hypertension, diabetes, smoking, hypothyroidism, a sedentary lifestyle, alcoholism, and a lower education level. Head injuries sustained early in life is also a risk factor for developing dementia as an older adult. The patient that will be presented has several risk factors for this geriatric syndrome. The patient examined for this presentation is a pleasant Caucasian 81-year-old female that presented to the clinic to follow up on recent lab work and her hypertension. The patient does have a 2-year history of vascular dementia and was accompanied to the clinic by her son. The patient has a 30-year history of hypertension and it has been well controlled on 5 milligrams of amlodipine daily, but her blood pressure at today's appointment is 158/82. She denies feeling anxious or stressed. Her son reports that the staff at the assisted living center does not monitor her blood pressure, but this could be arranged with an order from the provider. The patient and her son reported that she does take her medication daily, and the patient denies any headaches, visual changes, chest pains, shortness of breath, or palpitations. The patient has a past medical history of vascular dementia, hypertension, hyperlipidemia, hypokalemia, a CVA, COPD, renal mass, and osteoarthritis. She has no known drug allergies. Her surgical history includes an appendectomy and a hysterectomy. She was hospitalized in January 2016 after she suffered a massive CVA, which caused her to develop vascular dementia. She was hospitalized again in June 2016 for hypokalemia. The patient is a retired school teacher and has been a widow for 20 years. She did live independently in Nevada, but was relocated by her son to an assisted living center in Tennessee following her stroke in 2016. She is a former smoker and does not use alcohol. She has a strong family history of heart disease. Both of her parents had hypertension. Her father suffered a fatal MI at the age of 55. Her brother died from colon cancer at the age of 70. Because of this, she gets colonoscopies every 5 years, and all of those have been normal. She had a normal mammogram in 2008, a normal carotid ultrasound in 2015, and an unremarkable chest x-ray in 2017. The patient takes atorvastatin 10 milligrams, potassium chloride 10 milliequivalents, Aricept 10 milligrams, Plavix 75 milligrams, amlodipine 5 milligrams, and vitamin B12 500 micrograms daily. She uses an albuterol inhaler as needed for shortness of breath and Tylenol as needed for pain. During the review of systems, her son reports that she often has forgetfulness and is often unable to tell him what day or month it is. She frequently misplaces items in her room, and she is easily distracted. She often complains of bilateral knee pain, and she gets short of breath with activity. The patient and her son denied depression, changes in mood, fatigue, changes in speech, restlessness, or incontinence. Her son reports that he does not believe her dementia is worsening, but he only visits her 2 to 3 times a week for 1 hour at a time at the assisted living center. The staff has not reported any decline in function. During the visit, screening tools were used to further evaluate the patient. She scored a 5 on the Global Deterioration Scale, which indicates moderate dementia. This level of dementia requires care and help with medications and IADLs. The patient is still able to perform certain ADLs such as toileting, dressing, and assisted bathing. She scored a 3 on the Clinical Frailty Scale, which indicates that she is managing well and her medical problems are well controlled, but she does not participate in regular physical activity. She scored a 21 out of 28 on the Tenetti Balance Assessment, which indicates that she is at moderate risk for falls. She scored a 3 on the Geriatric Depression Screening, which does not indicate depression. The patient's vitals were fairly normal, with an elevated blood pressure of 158/82. She is slightly overweight and her body mass index is 28.55. She was oriented to self and place, but was disoriented to time and date. No other pertinent deviations were noted on her physical exam. Because this patient has an established diagnosis of vascular dementia and labs were drawn the week prior, no labs or diagnostic tests were indicated. If this were a new onset, a CBC, CMP, TSH, and a vitamin B12 level should be obtained. Other labs that could be obtained are a rapid HIV, ESR, folate, heavy metal screen, and a tox screen to assess for other causes of the symptoms. A CT of the brain or MRI could be completed to rule out other causes or pinpoint the disease causing dementia. Because many illnesses and diseases present with confusion and cognitive impairment, there are many differential diagnoses for dementia. If the diagnosis of dementia is made, the provider should test to determine the type, whether it be Alzheimer's disease, vascular dementia, or other diseases associated with dementia. Depression should be ruled out, and cognitively impaired patients should be regularly screened for depression. Delirium should be considered. Assess for infection, and complete the confusion assessment method to assess for delirium. All medications should be reviewed for side effects because certain side effects can mimic dementia. Brain tumors and subdural hematoma should also be included in the differential and can be excluded with imaging. Thyroid disease and vitamin B12 deficiency should be ruled out with a blood test. In addition, toxins should be ruled out if suspected. Patients should be screened for chronic alcohol use. A complete neurologic and physical exam should be complete to assess for Parkinson's disease. A thorough history is always indicated and can aid in excluding diagnoses from the differential. The final diagnosis for this patient is vascular dementia. The patient started exhibiting signs of dementia 2 years ago following a CVA. Her risk factors for vascular dementia include female sex, hypertension, hyperlipidemia, former smoker, and vitamin B12 deficiency. Her treatment plan is to continue her Aricept and all other daily medications. She is to continue her treatments with OT and PT. She will also have her blood pressure checked daily at the assisted living center to see if her blood pressure medication needs to be adjusted. Due to her comorbidities, her goal blood pressure is 150/90 or lower. Because this patient already lives in a memory care facility, there are no challenges or barriers to her treatment plan. The assisted living center that the patient lives in provides her with all the care that she requires. She has her medications dispensed to her, all meals are provided, her family visits her a couple times a week, and she has 24-hour care. Not all dementia patients are as fortunate as her, and many require their providers to set up home health and recommend community resources to patients and family members as part of their treatment plan. This patient has multiple health care providers. She has OT and PT twice a week at the assisted living center. She comes to the primary care office every 3 months for routine labs. She also sees nephrology every 6 months for a renal mass, neurology every 6 months, and cardiology every year. Primary care regularly receives office notes from nephrology, neurology, and cardiology, and are all on the same page as far as her treatment plan goes. Although many risk factors have been identified for dementia, are actions being taken to mitigate these risk factors? Many still think of dementia as a non-preventable disease. Although that is true in many cases, we need to educate our patients on the risk factors. This patient had many positive social determinants for health. These include access to health care, safe housing, work, and education. Patients that live in poverty and have a lack of education are at a greater risk of developing dementia. African Americans are also at a greater risk of developing dementia. A major socioeconomic issue regarding patients after a dementia diagnosis is made is a lack of funds for long-term care. Because of this, those patients do not have good access to care, which will lead to poor outcomes. One of the major legal and ethical issues related to dementia is autonomy. Determining if a patient can remain autonomous regarding their health care varies case by case. It is important to allow the patient to remain as autonomous as possible to a certain extent. A family member or surrogate should be brought in when a patient can no longer comprehend or make healthcare decisions. Dementia patients also have the right to treatment. Their diagnosis should not change their plan of care, especially if them and their family members want the highest level of care possible. After researching this topic, I learned several new things about this geriatric syndrome. Dementia is very common among older adults, and Alzheimer's disease is the most common type. Alzheimer's disease is also the 6th leading cause of death. I learned that majority of the risk factors related to dementia are modifiable. Because of this, as future providers, we need to educate our patients on these risk factors and ways to modify them. I learned that treatment for dementia is largely supportive and is aimed at lessening symptoms related to the syndrome. Dementia does not only affect the patient, but also their family members. Approximately 16 million Americans serve as unpaid caregivers to their loved ones with dementia. Family members need to be included in treatment plans and need to be provided with resources that can help them in caring for their loved ones. As family nurse practitioners, dementia is a syndrome that we will see commonly in practice. It is our responsibility to educate patients and families to the best of our abilities on this syndrome and to come up with the best treatment plans to improve our patients' quality of life. This concludes this presentation on dementia, and references can be viewed in the next 2 slides. Thank you.